Excellent, thank you, Olga. All right.
What?
Well, thank you all for joining with us. Susanne is joining now. Perfect. So as Olga said, the topic of this conversation is about developing and implementing remote patient monitoring programs at your organizations. And really what we'll be focusing most around are the exciting new reimbursement codes for remote monitoring that were implemented just in the last couple of years. With that being said, I will start with some introductions here for everyone, and then we will get to the discussion. And at the end of our time here, we have about an hour, we'll end with some time for Q&A that you can post in the chat box. So as a starting point, my name is Wes Haydon. I am the president and co-founder of CoachCare, and we provide a complete remote patient monitoring software and support solution. So helping providers to implement these services and to generate new revenue, from these new opportunities as well. Carrie, would you like to give a brief introduction, please?
Sure, absolutely. Thanks, Wes. My name is Carrie Nixon. I am the managing partner of Nixon Gwilt Law. We focus on digital health and life sciences innovation in addition to assisting healthcare providers. And we are currently serving quite a number of remote patient monitoring and telehealth companies.
Dr. Weitz, please.
Hi, I'm Sandra Weitz. I am a board certified pain specialist, anesthesia pain specialist, who basically started my own practice, grew it to 11 providers, built multiple related businesses, including an ambulatory surgery center, anesthesia company, physical therapy, imaging, and basically learned that by adding multiple revenue streams that you can horizontally and vertically integrate into your practice, that you can maximize your revenue while taking better care of your patients. And so now I'm teaching other physicians how to do exactly that.
Excellent. And Susanne?
Good afternoon. I'm Susanne Talebian, the co-founder of Healthcare Business Solutions. We're a full-service billing coding consulting firm working with clients across the country, and for the last few years teaching telehealth, RPM, focusing on virtual care, so we can help you with consulting or billing services. Happy to be here. Thank you.
Excellent. Well, yeah, thank you, everyone. So to kick things off, we have a series of questions I think will be pertinent to everyone's interest on this topic. But why don't we just start with, what is remote patient monitoring? And I'll kick off on that just a little bit to set the stage. So remote patient monitoring as a general construct is well, as it sounds, the idea of monitoring patients remotely, getting information, biometrics, vitals, and things like that outside of your traditional office visit. But what I think has really made this compelling, particularly the last couple of years, are, as I mentioned, some of these new reimbursement codes and reimbursement models that have come about that are really providing, I think, the right incentives for providers to offer these services in conjunction with in-office visits, or in some cases, potentially solely as a virtual provider. And so when we look at those reimbursement opportunities, what we're talking about is really a set of new insurance codes around two main activities. So one is for providing patients a set of biometric devices or a single biometric device, such as a body composition scale or a wireless blood pressure cuff, that kind of thing, and basically getting data back from the patient throughout their daily life to inform the provider's care in between those office visits. So provision of the device and that supply is an important aspect. The other aspect from an insurance standpoint that has come about is around the time you spend monitoring patients. And so this is the aspect of looking at the patient's data, whether it's from that device that we talked about or other sources of information that they might be providing, whether they've taken a prescription or supplemented adherence, that kind of thing. And then, again, having the provider utilize that information to flag patients that might be at risk, to escalate, their condition if it needs an intervention sooner, those types of things. And ultimately, the goal, of course, is to prevent readmissions and prevent adverse outcomes as a result. So that is RPM in a nutshell here, and really again excited to see that there have been some new reimbursement pathways that have come out in the last couple of years around that. But now let me hand this off to the rest of the panel here. So the first question we have to start things off is, why did CMS introduce these RPM services, and do you expect them to expand their support for them in the future? Right, a lot of questions around that. Carrie, given your background, why don't you speak to that first, please?
Sure, I'm happy to do that. So it's a great question, and I think sort of the when you come right down to it, it's the concept of something that doesn't get paid doesn't always get done. And so without the remote patient monitoring CPT codes that allow for reimbursement, there was really no way to incentivize practices to utilize remote patient monitoring for the benefit of their patients, aside from them actually, outlaying funds in order to support that kind of a program. CMS has come to the conclusion that remote patient monitoring as a care management service is intended to really improve quality for the patient while also reducing the overall cost of care over time. So from CMS's policy perspective, it made a lot of sense to them to provide reimbursement for these services. In the short term, yes, there is the cost to the Medicare program or any other commercial payer who's paying for remote patient monitoring services. However, there is clinical evidence and policy grounding in the notion that reimbursing for those services is going to create better outcomes and reduce the overall cost of care. So I believe that was CMS's sort of bottom line thinking on creating the codes.
Dr. Weitz or Susanne, any thoughts around that either?
I have a number. Susanne, do you want to go first? If not, I'll.
That's fine. Go ahead.
So I would echo what Carrie said in that basically, if you're not getting reimbursed, you're probably not going to do it, because at the moment, doctors are feeling an enormous amount of pressure to basically see patients. Reimbursement, everybody's talking about reimbursement is getting cut, and there's such pressure to put that next patient in, all right, that instead of, so let me backtrack. We are all taught in medical school this integrative approach, all right? We're all taught the biopsychosocial model of medicine, that we should treat the whole patient. But if you've been to the primary care doctor, all right, who has to see you in 5 minutes, there's not a whole lot of time in order to do that, all right? And so by doing remote patient monitoring, there are a couple of things. Number one, you can actually provide care to that patient when they're not physically in the office with you. You're still getting their data points. Number two, because the service can actually be provided by not the physician and not necessarily a mid-level, you can use somebody else to extend your practice, get that information, make decisions, put in place other programs for them, all right? Like, for example, talk about weight loss for a second. If I see that you're not, following the diet, then I can either hook you up with a dietitian, I can hook you up with a personal trainer, make sure that you're going to a gym. There are other things that I can do that don't involve my time and effort in that visit. And so I think that in the long run, both CMS and physicians are all going to be incentivized to continue this, because it really does improve the quality of care that we are able to provide without basically taking something more out of the physicians.
Yeah, that's an incredibly important point, just around the administrative burden, just the burden of time in general, that physicians and really all of our healthcare providers are seeing these days. Very good point.
Well, but
and
also,
real quickly, just to build on. Go ahead.
No,
I was going to say, just to build on your point, Dr. Weitz. Sorry, this is the downside of virtual conferences. Yeah, so to build on the point that you were making, about clinical staff being able to provide these services, that is an example of CMS sort of learning as they went, right? Because when the very first remote patient monitoring code was established and provided with standalone reimbursement, it only included physician time, right? And physician services as reviewing the material. And physicians went, I don't have time to spend 30 minutes a month looking at patient data. What I want is for, you know, my staff, my clinical staff, to look at this data and let me know when there's a problem so that I can intervene when it's important. And hence came the next iteration of these RPM codes from CMS that included that clinical staff time and, you know, made the program more feasible for implementation.
Well, but for the example I was going to give is that, you know, if you have somebody, let's say, who has high blood pressure and you give them a blood pressure cuff, okay, the physician, if they see that that there is an issue, or even if they don't see there's an issue, is not going to have time to do the counseling that it takes, all right? And so, you know, we'll talk about the codes of Susanne. Well, I'm sure we'll jump in here and talk about 20 minutes, 40 minutes, and 60 minutes. But patients love to talk, all right? And so for me to get on a phone call or a Zoom call with somebody and talk to them about their high blood pressure and why they need to control their salt intake and they need to not smoke and they need to adhere to the diet takes time and effort that I don't have. Whereas I can use a medical assistant who will be more than happy to talk to Miss Jones for 20 minutes, all right, and hear all of her issues with why it is she can't cut down on her salt intake because her husband loves salt, all right? And it's a reimbursable thing, so I don't mind paying my staff to do it, but the patient ends up getting the education and the better care.
Right, right.
Mm-hmm.
So just jump in here real quick. CMS finally realized, as you all have said, that these services do improve outcomes. They reduce the adverse events, and being in billing, coding, teaching it in this industry for over 36 years, you know, once Medicare approves something, that they've already done the studies, they've already done the background, they know this is a better way. So yes, they're going to cover it, yes, they're going to pay for it. The interesting thing I find is that physicians say, well, I'm already doing this. And I'm like, but now you can get paid for it. You should have always been paid for this. Now there are codes, you can get paid for this, you deserve it. And optimizing utilization of your ancillary staff, auxiliary staff is exactly how these codes were built, because CMS recognizes the importance and also the teamwork of the clinical provider's office. So it's a wonderful thing, and it's only going to expand and grow, and we're looking forward to that.
Yeah, this is great context, I think, for everyone. You know, one of the things we strive for in these types of conversations is to make sure that, you know, we give the audience some practical application out of the conversation. So why don't we dig into a little bit about you know, how this is practically implemented, right? If I'm sitting there, I'm a PCP, or I work for a health system, I'm in a department, you know, in whichever specialty, you know, how does this work? So Susanne, why don't you comment for a little bit around, you know, we've touched on this a little bit already, but who can prescribe this versus who delivers it, and that balance?
Sure. So we have the physician or the other qualified healthcare professional who will write the order for remote patient monitoring, remote physiological monitoring, and then provide a patient-specific goal. For example, you need to lose 30 pounds in 6 months, or you need to reduce your blood pressure to 126/80, you know, within 3 months. You need to have less than 3 high-level BP readings. They set the goals specific to the patient in the timeline. So that's who orders, obtains informed consent or written consent, and writes the patient-specific goals. From there, the auxiliary staff can review the data, monitor patient clinical data, converse with the patient via HIPAA secure email, text, portal, platform, etc. Also, when the staff is watching the clinical data, there's already a protocol set up within the provider's office that if there is an abnormality, that will be escalated to the provider to handle. And that's specific on the patient practice, the device, and what they consider an abnormality is. Of course, the auxiliary staff will also verify that it's not a issue with device or something, that they're not sharing their devices with their family members whose blood pressure is low because their athletic son or their grandpa didn't step on the scale or something else. There's some of these human errors we need to check off the boxes first and then make sure everything else is fine. So that's, we have the providers ordering it, staff monitoring, escalate as appropriate. Then the provider will sign at the end of the month, reviewing all the data, and then they will charge accordingly with the 4 CPT codes that exist for RPM services. And then the next month, the next series of monitoring begins, and it's based on the episode of care for that patient specific to their needs and goals.
Right. So if you're looking at that from a basic breakdown of time, to Dr. Weitz's point, right? This is 5% of the time is by the physician or the other senior qualified provider, and 90 or 95% of the time can be shared and delegated to other staff members, to your point, with, of course,
right,
escalations going back to the physician when needed, which is of course the point there. So then if we kind of extend that point a little bit, to the question of, how does this apply to me? How does this fit into, my practice as the audience, for example? What are there limitations around different groups of patients, different conditions or specialties that, that are, limited in this, or that can do it? I mean, where would you say this is a good fit? And really I open this to anyone, each of you have experience on this point.
Sure. I'll just start with my research on medical policies, reimbursement policies nationally for a majority of the carriers. First, we look at reimbursement policies to see how the insurance company is handling them, and not very many payers have policies on RPM services as of yet because they're new. They also don't call their policies RPM. It might be telehealth, it might be E&M services, so they're not exactly even sure how they should categorize these. Although CPT categorizes these services under the E&M category and is designated healthcare services. Then going into the medical policies, you'll need to check diagnoses that may or may not cover RPM services. So there's only a few that may have issues with the coverage, but I would say 98% of carriers that I've encountered over the past 18 months are covering RPM services and are following the guidelines by CPT and some by CMS. So we're very pleased to see that. Carrie and Dr. Weitz, I know you can expand on that, so please.
Yeah, I'll build a little bit on what Susanne said there as well. So her point about telehealth versus remote patient monitoring is a good one and an interesting one. And this is in the weeds, but sometimes it makes a difference in how you talk about remote patient monitoring. So for purposes of federal healthcare programs like Medicare in particular, remote patient monitoring is not telehealth. And that is because currently, COVID times aside, there are significant restrictions on Medicare's reimbursement of telehealth services. And those restrictions include being located in a geographically rural or underserved area, and being present at the site where the telehealth service originated at a rural health clinic or some other type of clinic. CMS recognized that those restrictions were simply not appropriate for remote patient monitoring. And so they made, for purposes of Medicare policy, a specific distinction between remote patient monitoring and telehealth. It is absolutely the case that many people consider RPM a subset of telehealth, right? That's just the normal way that they think about it. But I point that out because sometimes you will encounter with various payers them saying, well, we only do such and such with telehealth, right? And that may or may not apply to remote patient monitoring. So just kind of keeping that distinction in mind, may be helpful. The other thing I'll mention is that, as Susanne described, the RPM is considered an E&M service, and the individuals who can prescribe or order RPM are at this time limited to those who can independently prescribe and order those types of E&M services. And for right now, those are mainly physicians, nurse practitioners, and physician assistants, right? Those are the folks who can order RPM. I would love to see in the future that extended, that ability to order remote patient monitoring services extended to, for example, therapists, right? Both physical occupational therapists and psychologists and perhaps even licensed social workers. There are a lot of benefits to be gained from RPM in those care contexts as well. And so, I am hopeful that CMS will continue to build on their progress with the RPM codes and maybe expand the availability to those types of providers.
So yeah, I actually want to talk, hold on one second, if you don't mind. I'd like to talk about specialties, because I think that's, before we talk about getting outside of the physician mid-level world, let's just talk about specialties, okay? Because I think that there are a lot of people who are not thinking outside the box. Obviously primary care is, going to be able to prescribe a blood pressure cuff, a scale, a glucometer, and a pulse ox that I understand is coming down the pike. But think about it, all of the endocrinologists who are out there who are treating diabetes, all right, or even the nephrologists who are treating diabetes, anybody who's treating patients who are obese, so all the pain doctors who are out there, all of the sports medicine doctors who are out there, all of the orthopedists, okay? If you ask me whether you should get a knee replacement or a hip replacement before you lose your weight, the answer is absolutely no, because the outcomes already there that show that, having a joint replacement when you're obese is an issue. So that group is primed for that. All of the bariatric surgeons who are considering doing weight loss surgery should have these people on a weight loss program. They all do. Well, then why not sign them up for RPM for that? And, obviously, if you have a pulse ox option, then all of the pulmonologists, all the people who are doing sleep studies should be in that category. And I can go on. So I think the point is that a lot of physicians are out there thinking, oh, this is really a primary care thing. And the answer is, no, it's not. That basically it's for patients who have comorbidities. And even if you are a subspecialist, that comorbidity is affecting your ability to care for that patient, then you can use RPM as a tool in your tool chest to help them be compliant with whatever you're trying to treat.
Right.
Yeah, and that's
and this is actually, go ahead, Wes.
Just real quick, I think this goes back to the earlier point about how aligning the reimbursements here is going to drive our whole system towards better care, because like Dr. Weitz said, some providers are probably already doing some of these things. But by having the right incentive structure in place with reimbursements, now we're creating opportunity for that to be systematic, so that every PCP, or every endocrinologist has this in their tool chest, to your point, and that's how we move the needle in terms of health policy and better outcomes across the board. So, yeah, just really good point about how flexibly and versatile that is. RPM is.
The one thing that I will say, and I want Susanne to comment on this. My understanding is that only one physician can bill for RPM at a time. So the balancing act here is, if you're the PCP in town and you're buddies with the endocrinologist, you guys are going to have to come up with some dance so that you know, all play nice in the sandbox. Is that a fair statement, Susanne?
That is my understanding as well. Yes, only one provider will be reimbursed for RPM services. So yeah, and you're right, there will be some coordination of care on who's going to bill and who's going to be paid, which we also see with chronic care management and other care services. The patient does have to consent to these services. Hopefully they know what they consented to when they sign that form or are advised by their provider. You'll definitely find out on your first billing cycle if you're paid or not, and then you can, address that issue. Excuse me. But what you were saying is it is open to all specialists, all providers. Anyone who is trained in those services can render those services, and those who can bill E&M can order and bill for those services. So it is not limiting, and that's a great point to make, because I think providers just think blood pressure, glucose. And there's so many other conditions that we can monitor and track, high-risk pregnancies as well. So OB-GYNs can be in there too. Urologists with BPH and medications, anybody who's on multiple medications or prescribing that for their patients, which may be the urologist, not the PCP. So it's opened. Carrie, go ahead.
Yeah, no, you're right, Susanne. The language in this final rule, the 2021 final rule, was sort of less than fully transparent or clear about providers. Who could there be more than one provider billing for the codes? The language in the rule is, would seem to indicate that only one provider can be billed. I'm not 100% certain that that was actually the intent, and I don't know that it will remain this way, because it is absolutely the case that folks like the American Medical Association, who were involved with promulgating these codes, anticipated use by various specialists, right? So right. It would be very common to have a patient who was seeing a cardiologist who would be monitored for particular aspects of heart disease, while at the same time being seen by an endocrinologist because they have diabetes. And those are two they're two separate but related episodes of care by two different physicians, specialists, both of which lend themselves to remote patient monitoring quite well. And we'll see what happens in the future with that, because to Dr. Weitz's point, these codes are very appropriate for specialists as well. Right. And it would be a shame for one specialist to not order remote patient monitoring because they found out that another specialist has a different episode of remote patient monitoring going on at the same time, and so they can't get reimbursed for it. That just doesn't make sense from a policy perspective. So we'll kind of see how that plays out in the future. I wanted to mention also a little bit of confusion around the 2019 Medicare physician fee schedule that referenced sort of this set of the new set of codes, the three at that time, 99454, 99453, and 99457. They were referenced as chronic remote physiologic codes, and it is absolutely the case that these codes are not limited to use with to patients who who have chronic diseases. It is the case that they can be used in acute circumstances. COVID is an example of that. A patient who is going in for knee surgery who does not have any other sort of pre-existing or chronic conditions, it's also appropriate for an episode of monitoring sort of after that knee surgery. CMS has clarified that in this current 2021 rule, and everyone should. There has been the misperception that it was only limited to chronic patients, but that is affirmatively not the case anymore.
Mm-hmm. Now, I want to be a little bit sensitive to our time here and leave some time for questions and answers. I think there's just one other point I wanted to touch on briefly before we do that, which is, just again, practically speaking, how is this implemented? And, for my 2 cents on this point, and Gigi just sent me a list of questions. We got some good ones there. Just as far as implementation, look, this is where I think technology has really become just a really invaluable part of this, whether it's things like helping keep, track the data remotely, of course, having technology to do that, the ability to track the whole audit trail and things of that process, the claims and all that, is really quite valuable. So I think, these are certainly areas we can get into in more detail if it's of interest to anyone after the conversation, but there really have been, a lot of good resources that have come about in the last couple of years to make this pretty seamless process. And at least for our 2 cents, we found, whether it's an individual practice, single doctor, all the way on up to a health system, we've seen these processes get implemented within a matter of days, maybe a month or so if it's a larger organization, but it can be done pretty seamlessly. And I think it just goes back to the fact that this is such a this is something that can be delegated and done versatilely with so many different members of the team as a result. Any of the rest, do you have other questions or other comments around just implementation, how you've seen that play out? I hear that as a concern oftentimes from clients and prospects.
Well, just one quick clarification that CMS made this year as well, and Carrie, you can confirm this with us, everyone, is that the 20 minutes is not a 20-minute live interaction call. It's 20 minutes per month accumulative by all staff in monitoring, tracking data, working with the patient, and also the live interaction. And that had caused a lot of confusion previously, that 20 minutes per month includes all those activities. Same with the 99458 code, the additional 20 plus 20, you can charge that with 2 units, includes all those activities.
Excellent.
Yeah, absolutely.
Now let's, why don't we speak to some of the questions here? There's some good feedback. And I will say just for the audience that any questions that we don't have the opportunity to answer during this call, if you, CoachCare, we're a sponsor, you can find us on the website. If you'd like to speak more about this with any of us here on the call, we're happy to follow up on any questions we don't get to in the conversation. First question here for everyone is, what, if any, HIPAA issues are there with remote monitoring of patients? Actually, just given my experience from the technology side, I'll say that HIPAA is very much an important factor in this. You do need to be HIPAA compliant in review of this information and so forth. So, it's important to make sure that whether it's from an administrative standpoint in terms of your team and how they utilize information, of course, following HIPAA guidelines there. And then I think probably most importantly, or most front of people's minds around this, is the cybersecurity. You definitely need to make sure you're using a tool or tools that are HIPAA compliant, that encrypt the data, so you're sharing information and using encrypted. That's an important piece. But as I said earlier, there have been a lot of tools that have come about to really do some aspects of this effectively and to fulfill those requirements. Let's see here. Where are they?
Before you go to another one,
yeah.
Wes, before you go to another one, can I chime in on the HIPAA thing for just a moment? So I'll also note that the FTC, the Federal Trade Commission, has recently issued sort of a consumer alert saying, hey, you consumer should be aware of how your monitored health information and how the devices that you're using, that are being used to monitor your patient-generated health data, are how that data is being used. You have a right to know that, and it's something that you should question. So, I think that the issue of privacy is coming more to the forefront in the minds of patients, and they may even have questions about, privacy and how their devices are collecting their data, storing their data, using their data. And last thing I'll say is that NIST, the National Institute of Standards for Technology, I think, has recently issued some guidelines around remote patient monitoring and privacy protections. So you can check those out if you need to.
Well, and I'm going to chime in for a second, because I think, obviously what software you use, what platform you use makes a difference. But from the physician office perspective, every physician's office should have a HIPAA policy, right? We are required to do HIPAA training of every new employee, every provider. It needs to be updated every year. So there should already be a HIPAA plan in place in all of these practices. Nowadays, everybody has an EMR, right? We all have portals that patients can access. And so from the physician office perspective, those HIPAA concerns should already be being addressed. And this is really just an extension of this. It's just another platform.
Absolutely. And just for the panel's edification, we've got quite a few questions. So I'm going to try and touch on each of them briefly from here, since we have about 15 minutes left. Second question, how did you choose your platform? So I'll just give 2 cents on this, which is just that I think, look, obviously I'm a bit biased that as we provide, these tools ourselves, but I'll say that, there are a couple aspects of, I think, successfully implementing RPM. Having the right tools, whether it's the devices, the software, is certainly an important piece, but there's also the support and the expertise around workflow and billing that are critical as well. And I can say that you need to be looking to solve for both aspects of that, so that your staff feels comfortable with what they need to do to implement this successfully, so that your billing team feels comfortable. And so having both aspects of that, I think, is a pretty important piece. Do you all have any other thoughts on that?
One of the things I like about some of the platforms that are available is the ability to have a patient-facing app. Some of the software programs that are available really only are physician-facing, meaning the physician collects the data, but the patient doesn't really have any interaction with it. Having a patient-facing app is going to increase the patient's compliance. All right, and given the fact that you need to have 16 measurements a month, if all I'm doing is sending you data, but I don't see anything, I don't really have any involvement, my incentive to do that goes down. And so, in order for this to really work, it needs patient buy-in as much as it needs physician office buy-in. And so think about that when you're choosing a platform.
I agree. It's patient buy-in, patient commitment to RPM, and they'll see better outcomes, and the provider commitment. So when the patient can see they're actively involved and held accountable to improve their care, then that does result in better outcomes for the patient. I've seen several app platforms reporting purposes for billing, and they're not usually user-friendly or helpful. There are some that are outstanding and really work with the customer. So helping the clients bill correctly is important, extremely important.
Yeah, absolutely. The full process, start to finish. Let's see here. There's a question, Susanne, you probably can comment well on this, given your experience. Where the question is asking, I think, what states are you seeing RPM coverage by insurance companies? Do you want to speak to that for a moment, Susanne?
Sure. I've checked, our company has checked coverages in 35 states across the country with different clients, and we're seeing coverage pretty much everywhere. We do have one little obstacle with Cigna. They have them listed as miscellaneous codes, so we're working really hard to break into connection with the medical director, and get that resolved. But from New York, Pennsylvania, Long Island, Florida, Louisiana, Texas, California, yeah, no problems with coverage. I've seen a lot of good coverages across the country.
Well, and Medicare is, Medicare is obviously.
Of course, Medicare and Medicare Advantage cover.
Yeah.
Yes.
Let's see here. We have, Okay, given that CoachCare has been doing this a long time, how are reimbursements since you started to where we are now? So given it's directed to me, I'll answer real quick, but I think you guys have comments too. So, reimbursements around this started in 2019. I think the reimbursements have basically been, as far as the existing codes, been stable since then, which is an important consideration because, as you might imagine, in some other services in Medicare, they've gone down given COVID and money going elsewhere. So that's a really positive sign to see that that's been pretty stable in our experience. The other, I think, important distinction is they actually added a code. So in 2019, there were 3 codes. There's one code for time monitoring for 20 minutes. And then in 2020, they actually added a second code called 99458, which actually added an option for doing 40 minutes or 60 minutes of monitoring. So they, the rates have been pretty stable, and then the addition of new codes just shows strong reinforcement from government and in turn through private payers. I think we've generally seen that about the same. What do you all think on that?
I agree. Even with Medicare tweaking the RVUs, the work RVU, decreasing the overall conversion factor by 11% almost this year, and then upping it a bit. And like I said, the work RVUs, RPM codes took a minimal discount. So that's wonderful. They recognize the importance of the codes and they want to pay for them. So it's a good thing.
Yeah. Well, let's see here. We've got what type of new positions / jobs or expanding scope of the current ancillary staff do you see the need for in the future? So I think this question is around, implementing RPM. What does that mean for staff?
I think it really boils down to the volume of patients that you have. I mean, I actually built out a calculator trying to figure out this exact number. And the bottom line is that really until first of all, most offices have enough redundancy that they can find a medical assistant to do some of this, even without adding staff initially. It's not until you get to about 50 patients a month. All right, and again, depends on whether they're spending 20 minutes or they're spending 40 minutes or 60 minutes, but 50 patients a month, you are still probably well within your current staff. At that point, you may need to add 1 FTE in terms of a medical assistant. If you plug into a calculator, you will see that the cost of that medical assistant pales in comparison to the revenue that you're going to generate from that.
Yeah, and I'll also say that the change from the direct supervision that was initially required of clinical staff who are doing the monitoring to general supervision, meaning the clinical staff need not be co-located in the same physical location as the supervising physician, has allowed certainly a lot more flexibility in the types of business models that develop around remote patient monitoring. It is the case that some RPM companies offer outsourced, monitoring services. They have clinical staff whose entire sort of job is specifically to do that. Now, some offices want that and some offices don't. They want their own staff, looking at the patient data and being responsible, but that is permitted at this point.
Yeah, but I just want to jump in and say one thing about that. If this is really, at the end of the day, about providing the best quality of care and having that relationship with that patient, it really is about having an MA or somebody in your office that the patient recognizes that the patient is somehow going to have a relationship with, because that's how you're going to get that patient buy-in. Right, and that's how your outcomes improve. If we end up outsourcing this to somebody else and it's just some other service and it's not really part of that doctor-patient relationship, because even if I'm not the person who provides every single piece of care, but my patients know that my medical assistant talked to me and I'm actively involved, I have a much better chance of getting that patient to actually comply.
Yeah, the relationship, absolutely, it's important. Let's see here. We've got, this is a good question. Telehealth and the telehealth and the opioid crisis. Is this a potential solution? So I think, I know Dr. Weitz has some comments. I think for my part, I'll just say real quick that I think that one thing we didn't really talk about is how some of the different codes, how they can be used together or separately. So we've talked how there are these device codes for offering a scale, blood pressure cuff, that kind of thing. You know, there aren't necessarily devices for certain conditions, and so it just came to mind talking about opioid crisis, but that doesn't preclude you from using the time monitoring codes. So even if you don't have a device you want to offer somebody, it's maybe not as relevant to their diagnosis, you can still use the time monitoring codes. These tools still apply for you. But Dr. Weitz or others, please feel free to add.
I have a very hard time seeing how this would actually help you with the opioid crisis, you know, because realistically, the way, as a pain management doctor, we did urine drug screens, we did pill counts, live pill counts. Those are things that you need people physically present for.
Mm-hmm.
So I think that that's, you know, yes, you could do counseling, but I think that would be the extent of it.
And let's see here. We've got, just give me a second. Here's a good one. Face-to-face versus telehealth, or I guess face-to-face versus the remote monitoring in this context. For the same services, is there a difference for reimbursement? Well, obviously, RPM is a little bit different than an in-person visit, but any of you care to comment on that?
Yeah, well, I'm going to comment on it from a physician perspective. If I see you once a month for 15 minutes, 20 minutes, even if I spend, if I bill a 99214 or 99215, that is all my time, and basically it's with you and it's once a month, and I have only one data point. Whereas if you look at the reimbursement, if I spent the same time amount as a 99215 and gave you the device, and Susanne, I'm sure will correct me if I'm wrong, I'm actually going to generate more income, more revenue from that, and it's not requiring my physical time. So in terms of which way, and I get many more data points. So I get much more information, much better care for the patient, and comparable or more money for less effort on my part.
Right. Exactly. If you're talking straight return on investment, RPM services will generate more than a 99214, 215. And as the doctor said, it's not her time being spent the majority of the time. So you're optimizing by using that level of staff appropriate to monitor those services. So provider is able to see other patients. Clinical staff is doing what they can do in their scope of practice and being general supervised. The patient is held accountable for their care. And I think we really need to remember, in a value-based world here, we're holding providers responsible to make better outcomes. But it's all dependent on patient compliance. If the patient is not compliant, the doctor can turn blue, and the patient's not going to be compliant. So getting those better outcomes involves doctor, staff, and patient equally. So I see RPM as an extremely strong tool in your toolbox to prove that you're rendering value-based care to your patients, that you're working hard to get those good outcomes. And when the patients are non-compliant, I have no problem telling my clients, you mark them patient non-compliant. This is medically necessary services that the provider is offering and recommending. The same thing, if they asked you to get a CAT scan and you didn't get it, you're not compliant. If they told you to take a medicine and you're not taking it, you're not compliant. Same thing with RPM. So I feel very strongly about this point that it's a win-win-win, provider, patient, and insurance company. And I'm not usually on the side of the insurance company, hardly ever. So it is win-win-win.
Yeah, absolutely. Well said. Let's see, we only have a couple more minutes left here. Give me one moment. So I think this is a good one. We can probably close on pretty succinctly. So this audience member is asking about whether RPM can be used in a post-surgical setting. So an orthopedic practice who performs a hip replacement, how does that look? We touched a little bit on this earlier, but perhaps Dr. Weitz, do you want to expand on maybe some of your earlier comments on how this can apply?
Yeah, I mean, I actually would tell you, I think it's probably pre-op more than even post-op, because it's all about patient selection and patient outcome. And if you are a surgical practice and you want to basically tee up patients to have the best possible outcome, then making sure their blood pressure is controlled, making sure that their weight is controlled or optimized before you operate on them, then great. In the post-op setting, most of the orthopedists are not monitoring their blood pressure nor their weight, and most of them are not active enough at that point to give them a weight loss program and think that they're going to be compliant. So I don't really see it in a post-op setting. I see it really very useful in a pre-op setting. And I think that on a totally outcomes basis, right? If I'm an orthopedist and I do RPM and weight loss and go to the insurance company and say, hey, I put all these people on a program to lose weight. I only operate on those people who are compliant with my RPM weight loss program. I only operate on them when they get to X, Y, and Z, and therefore my outcomes are better. I have, more patients who finish their therapy, or more patients who go back to work, or whatever the outcome you want to monitor. Then that orthopedist is going to be able to negotiate for better contracted rates than the guy who's not doing that. Susanne, am I wrong?
No, you are absolutely correct. Showing the better outcomes is what is needed, the data that's needed. Recently, I've worked with a Care First of Maryland on helping, along with many others, with getting them to define a medical policy for RPM. And their questions were, well, for what diagnosis should we do? For what lengths of time should we do? The insurance companies don't know. This is where the role of the providers is extremely important. And right now is the time. If you're implementing RPM, you need to implement your outcomes tracking too. You need to set those data points. You need to give the insurance companies that information and prove to them it's better and say, so, I did 60% less surgeries because the patients weren't compliant. They were going to re-need them, need a second surgery or an adverse event. But those 40 that I did work with who were successful, lost the weight, had shorter stays, less disability, less outcomes, and were quicker to return to work. And those all count in value-based care. So I tell all the clients I work with, as soon as you start RPM, let's start an outcome study. And, it can be 2, 3, 4 points for whatever specific diagnosis, and gather that data. And let's tell the insurance companies what they should pay for instead of the other way around.
Absolutely. All good thoughts. And of course, having good tools to help you track all that is an important piece. You can't change what you don't measure, right? So with that being said, festival team, if you wouldn't mind putting up the little slick that we had that I'll mention, if there are follow-up questions and you go onto the sponsor list on the website, we have a little slick here. They're gonna show up that just talks a little bit about how to implement this, some of the benefits. It includes links to all of our websites and things if you have further questions. So appreciate everyone's time here, and I think we'll close with that. So thank you very much.
Thank you.
Thank you,
everyone.